there are some action items that you guys will have to do to complete to get these CEs and CMEs. There's two different processes. The CE you do have to attend, and the CMEs be a course for the whole entirety to get the full 2 hours. The CEs, we will send a post email with all the information, and you will have to fill that survey out within 2 weeks. After 2 weeks, it will close. So make sure you do that. And then at the end of this presentation for the CMEs, they will be a text message that you will provide, and they are through Case Western, that you will have to do the briefing after it to complete to get the CMEs. Any questions on that? We are going to move forward then. We do have a great setup for you today. It will start out with Dr. Dahl-Grove, who is the lead PI, kind of discussing what Region 5 for Kids are, what resources and what we can provide to your facility for training. We will move into medical surge with Dr. Kocken, who's out of Minnesota, and she will do an excellent talk on learning about pediatric medical and disaster surge. Then we will transition to Dr. Dingeldein, who is a trauma surge up in Rainbow Baby, and he will talk about the broad spectrum of treating and managing a trauma surge. Then we will go into learning about pediatric care and do case studies that will really help you on what best practice care that you can provide to your pediatric patients when they arrive at your facility. We'll have a 5-minute break for you guys to get your tea or your coffee, and then we'll come back and we'll end with a specialist that teaches our TCI at NCH on crisis behavioral, and she has developed a course that will focus on role and critical access on resources that are tailored to your area and ways to de-escalate and how to get them into the referrals. And then we'll end with a poll. So we are going to start with a slight poll really fast to get you guys engaged. You will have to scan the QR code. If you can just type in your name and like if your credential RN, MD, and then put where you're from as your last name, that would be great. But I'm going to give you a couple seconds to register. Can you give me a thumbs up if you guys are registered? Okay. All right, the first question is, if you could hit the next slide. During a pediatric direct disaster, what is your primary role? And you can see the results we're getting in there. All right, so most of you guys are hospital-based, which is awesome. That kind of helps tailor our providers on what they're going to talk about. All right, we're going to move to the next question. All right, and this is a simple, easy question. Have you had any prior education on pediatric annexes, pediatric disaster plans?
So it skipped that question on my poll. I went to the next one about prior education or training on pediatric trauma. Oh, there we go. It's back.
Oh, there it goes. Thank you. All righty. So we're 50-50. Well, that's good. All right. And then our last question, is it showing? Oh, here. No, I activated it again. And so somewhat knowledgeable. Okay, well, we will do a poll at the end to kind of see if we've gained some knowledge from this. So we are going to move forward. And Dr. Dahl-Grove is going to do her welcoming remarks.
Hello, everyone. I want to welcome you to this webinar. We've worked with Kelsey. Actually, I've worked with Kelsey for a long time. I'm a pediatric emergency medicine physician at Rainbow in Cleveland, Ohio. I've worked in the disaster space for pediatrics for probably coming on close to almost 20 years. I want to welcome you to our Region 5 for Kids, which is a pediatric center of disaster excellence, which was funded by the ASPR in 2019. There are now 3 of us. We are joined by the Gulf 7 as well as the RAPM group in California. And these are the objectives that we were asked to do with the ASPR back in 2019. We were funded, and then we had a pandemic in the middle, so we shifted a little bit, and we continue to have things like respiratory surges that impact all of us. And so we really are working to obtain the goals of just trying to coordinate pediatric disaster care across the Midwest, working with all of our partners in Region 5 for Kids, which incorporates most of the Midwest. So you can see that we're working to strengthen disaster plans and coordination, enhance the state capacity for pediatrics, as well as increase professional educational competency, which I hopefully will help by you guys participating today, as well as create situational awareness around pediatric disaster care. So we have a lot of elements that we work in all of these places, but we actually partner with our colleagues at the Emergency Medical Services Innovation and Improvement Center, as well as the newly formed Pediatric Pandemic Network. And so these are really important resources also. This is a slide that just kind of goes over our mission and goals, which is really to build foundational clinical care across the spectrum for everybody at different levels, as well as really increase disaster preparedness and response capabilities among both hospitals as well as regional healthcare coalitions and first responders. Next slide. This is the a schematic of where all the work gets done. I have a co-PI, Charles Macias, here at Rainbow, but we also have a ton of work groups where a lot of our work gets done. And so it's just a really great group of people at different partner institutions, and I definitely could not get all this work done without them. Next slide. So this is just sort of give you an idea of what we've been doing. We partner with mostly children's hospitals, but we can't get any of our work done without actually working with our state entities like the like Ohio Department of Health, as well as the regional healthcare coalitions, who pull in a lot of the pre-hospital providers, as well as other important entities that work in a region. We've been able to pivot during the COVID response to work on some educational pieces and things like that, as well as during the recent respiratory surge. And because we know each other so well, it really allows us to work on kind of a smaller scale within the region. And I think one of the, what I'd like to think of one of the potential successes is being able to reach out to somebody like Kelsey and say, hey, what is really needed down in your region in Southeast, especially in response to the respiratory surge, which I think caused a great impact, not only on the children's hospitals, but also on all of the smaller and critical access hospitals that don't really usually have to take care of those super sick kids for a really long period of time because they're able to transport them. So I think that these have all been important concepts that we've worked through in collaboration with our other partners. Next slide. This is just one example of what I'd like to sort of show you guys that actually exists. So this is a pilot project that is actually going to probably be live hopefully soon. This is a picture of a pediatric bed board out of the state of Michigan. that they actually use on a daily basis. It's created by Javari and EM Resource. And I think many of you know that Ohio recently just went to EM Resource and Javari, and we will have a similar pediatric bed board that it should be available for viewing to understand where the pediatric beds are, what type of beds are available across the region. We did exercise this back in October, and if you follow the QR code, I think you'll probably be able to go to the website and see what that recorded exercise looks like, and it sort of talks about how you might be able to use it in a real live incident. Also, we hope that something like this would help cut down on the amount of time that a community hospital might have to do in calling around to look for a bed, because they can actually go to a bed board. And if you use it in daily practice, like hopefully we all will at some point, it would be a great tool to be able to see where the pediatric bed capacity is. The next slide. We've also worked on some other projects, which I think you may or may not be familiar with, but we created back in 2001, 2002, 2021, 22, they created a pediatric specific HVA, which I think many of you are familiar with the regular HVA, especially at the hospital level, but we created an HVA that is meant to be kind of used more at a hospital/regional level to look at pediatric specific needs, includes more around pediatric mortality, schools, daycare, family reunification items. But these are things that are really important to children that make a difference in their life and really impact them if they're missing. We also created a companion tool that is called the Regional Metric Scorecard. And this is something that aligns with some of the aspects of the pediatric annex, which was created back in 2019, 2020. And this is a tool that really looks at some of the social and physical determinants of health related to pediatrics, accesses information in federal databases, and is actually available to be used by anybody. And we actually have a live version of it that is available online. The web-based version of the HVA will probably be available in late 2023 to into 24. Next slide. This is just an example of some of the educational infographics that we've created. We encourage you to visit our website, and these are downloadable. But we've done things around active shooter as well as behavioral health. We've created sort of gap analysis through a compendium that looks at, how to approach pediatric disasters in communities, as well as we've done all our workshops. And so these are all available with recordings actually on our website, which is on the Emergency Medical Services for Children website and under the disaster tab. Next slide. So these are just examples of some of the exercises that we've done. Really low stress environment, usually anywhere from 2 to 4 hours, just depending on the number of people. But we've looked, we started out with a darkest winter that looked at a viral respiratory surge, which we didn't know would be predictable. But we also did a reunification workshop. We've done a telehealth capability virtual workshop that sort of demonstrated different telehealth capabilities that might happen in a disaster. And we probably got to use some of those in the recent fall surge. We've done another one on really cool idea of a pediatric coordination center, which is something that would be embedded into like a state medical operations center, but it would have a pediatric arm to it so that there would be some specialization there. So that, in a big pediatric surge, we may be able to call on somebody like the state and say, hey, we're having a big surge down there. Can you help us? Our resources for pediatrics are minimal. And so, help us access the pediatric resources that are in the state of Ohio. But some really great ideas. And the exercises are really nice to be able to do. It sort of gives you a chance to come in, talk with other people that are like-minded and work through them. So encourage you to think about, if you're interested in having us run a small pediatric exercise for you, reach out to us and we can help you figure out how to do that. Next slide. This is just the concept of the Pediatric Medical Operations Coordination Center, which may be able to be embedded into something like a medical operations center at the state level. But the idea being that in times when it's not needed, it actually can be a source of education to help, sort of spread more educational tools out about taking care of kids and things like that, as well as looking at preparedness plans. But then as a potential response unit, really helping to integrate maybe telehealth capability and capacity across the region during an actual event and helping pull in resources. So a really cool concept that I'd really like to see us be able to implement in the state of Ohio. Of course, as with everything, these all take time, but if you think this is a really great idea that would be something that would be helpful, I would encourage you to reach out to Kelsey or even to us and let us know what you think about it, or if you'd like to learn more. Next slide. So our projects this year have really concentrated on really reaching out to what we call the rural and critical access hospital regions, because we really want to help those individuals that don't necessarily take care of a lot of kids on a daily basis to be able to feel a little bit more comfortable, as well as looking at implementation of our Javari situational bed tracking board, which is going to be live hopefully in all of our states within the next few months. Next slide. These are some resources that I want you to consider using. The Pediatric Disaster Checklist is a great tool that's been recently revised. It has 11 domains on it, and it's up on the Emergency Medical Services website. There's also a couple of videos that go along, because we did some workshops for the state of Michigan on specific components of that, including surge, behavioral health, things to look at. We have some infographics and some videos that are tips for families with youth and children and youth with special needs. And so I encourage you to look at that, as well as our pediatric disaster education concept of operations, which is a community-wide kind of looks at the education that's across the spectrum. And then there's also a pediatric unification toolkit, which can actually be very helpful if you want to look at your reunification plans, either in your community or at your hospital level, just depending on who's going to be using that. And I think there might be one more. It's primarily contact information. And now I'm going to turn it over to Dr. Paula Kocken, who I think is our next speaker. Thank you, everyone. Please reach out to us with questions. We're so glad you're here.
All right. Well, everybody take a deep breath and welcome to the workshop. We're going to be talking about pediatric medical surge in this part. And the primary thing is that one of the things I want to get across is that you need to realize that this is going to happen at some point in time to your hospital, to your community, that there would be a surge of pediatric patients that are having a medical problem. Everyone currently is really focused on trauma, and that will happen in our next talk. However, this area is one that can sneak up on you, sort of like what happened during our viral surge time, or can be a very abrupt episode of a disaster. So next slide. So what is a medical surge, or what is a surge? A surge is an amount of patients coming to your hospital or your clinic or to your community that is beyond what you would normally be able to handle. And if you were at a children's hospital, that might be 30 or 40 patients. However, if you're at a smaller institution, it might just be 5 or 8 patients that come there. One way to handle this, and we'll talk about this in a small amount, but is a good area to focus on to keep ready, is the daily readiness. Keeping your specific equipment for pediatrics, medication, and training at a higher level so that you're always thinking about, well, what would happen if I had 3 or 4 kids that I had to deal with that had this problem? Examples of medical surge would include medical problems, like if they had a carbon monoxide poisoning episode at a children's swim meet at a local YMCA, or insecticide exposure from a tanker truck that might have derailed and been close enough to the school. Actually, thinking about the train derailment in Palestine, was another good episode of a possible medical surge, because it was not a traumatic episode. Very few people got injured. It was more the exposure. And then finally, as I said, the triple viral surge from RSV, influenza, and COVID really caught a lot of us as a medical surge that we weren't quite prepared for. Next slide. So the purpose of this talk is to focus on specific areas of your surge plan and being aware of what your surge plan is, having the key areas and roles that you would need to fill, and also some of the red flag situations that would come to light during a pediatric surge. So the first thing is having a plan, and all of the hospitals and all of the healthcare coalitions have been tasked by ASPR to create a plan, but to know where it's located and to know how to use it is the wisest thing. I'm always concerned about having everything online and then the power goes down. Then how do you handle your plan? So you probably should stash a copy, a hard copy, in a 3-ring binder somewhere near your area of operations so that you can pull out the plan and be able to look at it in case power goes down. And then the other thing is to make sure that people know about it and can use it. When making the plan, it's fine to talk in broad terms, but to keep it very simple as to how you would trigger the plan, who is allowed to trigger it, and what is done after you've started worrying about a surge. So in essence, at my institution, I work at Children's Minnesota. The charge nurse in the ER can trigger the plan. The on-call nursing administrator can trigger the plan. It's very open, and it's fine to start it. And if they have to pull it back and say, oh no, we don't need everybody, they can do that later. But pulling in your people for the incident command center really helps figure out what to do. If you have concerns that your plan is not adequate or you don't like your plan, you can look at the ASPR Tracy site on the HHS government site, and there are plans there that are available for copying. Next slide. So when and why to trigger? As I said earlier, that different volumes of patients and different severities of illness really make a difference as to when you're going to have a surge. It could be 10 patients during a day shift, but it might be only 5 or 3 on a night shift where you need to bring more people in. It could be 10 patients that have some respiratory problems that aren't doing too badly, or it could be 1 or 2 patients that are very severely compromised. And so knowing that it isn't a specific number or isn't something that is written down, it is whatever your hospital cannot handle. Another thing is, like when we were dealing with the respiratory viral surge, almost all the hospitals in regional areas were under the same constraints and had the same volume of patients. And so this would also cause a possible surge of patients, and then you'd need to have your incident command center set up. As I said earlier, in my hospital, just about anyone can trigger the plan, and then it can call in the hospital administration to help out. But the deal is you have to know what to do until the administration comes in. So being able to flex the control is important. Okay, next slide, sorry. So the key areas that I see in a surge are the front door, which I always consider my ED as the front door of my hospital, and how they're going to handle the patients, and in other words, to triage. So knowing if you're going to use jump start or assault triage or SALT triage plans. And then the second thing, which is very complex, but you have to have a simple way of tracking the patient so you know where you're putting the patient and who's going to see them. And then if you can't handle them in your institution, a plan for triaging them elsewhere. Another area for pediatrics especially is the family reunification area. And as Dr. Dahl-Grove pointed out, the AAP has a nice toolkit on family reunification. And the other area would be that having unaccompanied minors in a separate area from the unification. Okay, next slide, please. The key roles include the incident commander, the communications expert, and the subject matter experts. Subject matter experts may be virtual, so that's where you would just call them in from a virtual medicine situation. Next slide, please. Red flags. This is something that kind of is ingrained in the pediatric emergency realm, but not necessarily in the general medicine realm, that you need to be aware that children are a little bit different. You've got to pay attention to dosages. They are oftentimes more susceptible to absorbing toxins, either because they're closer to the ground for heavier gases, and that pediatric patients deteriorate quickly, but they also get better quickly. So really reassess. The other thing is to know your antidotes and your medications. We'll go on to the next slide. And then a lot of medical surge can be from contamination situations. So realize that you're going to be decontaminating children. And one of the easiest ways to decontaminate children is to keep them together as a family so that the parents can help decontaminate the child. The other thing that's very important is that children don't always tell you it's too cold or it's too hot. So be aware of the temperature and pay attention to taking care of those children. Next slide, please. Children are not little adults, so you have to be able to understand that they may not tell you anything and you won't be able to keep track of them. So it's a little bit different. Sometimes you have to assign people to them. Next slide. And then these are the sources. Dr. Dahl-Grove also had a list of the sources. I threw in the Pediatric Readiness Project. That's the PEDS Ready evaluations of hospitals and agencies. The EMSC, we'll be quoting that over and over again. And then American Academy of Pediatrics has a good disaster area on their website. So next slide. And oops, you didn't. There was my contact information somewhere in there, and a thank you. So you can get a hold of me through the ASPR group or through Southeast Ohio's. They've got my contact information. That's all. Thank you very much.
Hi, everyone. My name's Mike Dingeldein. I am a pediatric surgeon and the pediatric trauma director up at Rainbow Babies and Children's Hospital in Cleveland. And I get the pleasure of helping out with the FEMA or the Region 5 for Kids grant also in their trauma domain. So purpose of my part of the talk is really to reinforce some of the concepts you just heard in the last presentation around, kids are a little bit different. You need a triage mechanism for kids. You need a reunification plan for kids, all those things that you want to think of, but maybe take a little more of a spin looking at the, the traumatic aspects of it. So it's managing a pediatric trauma event and critical access a rural community. Next slide, please. The basics of this, just like Paula was saying in the last talk, is that the best way to be prepared for a surge of pediatric patients is to be prepared for a single pediatric patient, right? It's taking that time every day to think about if we had a sick patient coming in, whether a medical issue or a sick, injured child, how are we going to care for them? Do the people in my team, the staff, docs, everyone else, do they know how to help care, at least stabilize an injured patient? Why does this matter? Well, we'll talk a little bit about some of the statistics because this is going to happen, right? Even though this is a relatively rare event, injury, trauma is the #1 cause of morbidity, mortality in children and adolescents. Why do we separate out pediatric care? Well, because there are some true kind of anatomic and physiologic differences with children that are important to know, especially as you're assessing them in a potential traumatic mechanism. And you, Michelle, feel free to just click through these. What are the limiting factors for pediatric patients in potential critical access hospitals or community hospitals? Well, there's a variation of pediatric requirement for nurses and physicians by specialty and training programs, right? This really can vary by state and how you did your training. Most EDs see fewer than 15 pediatric patients a day. There's limited supplies and familiarity with the pediatric equipment. It's just not spending the time laying hands on the pediatric equipment. Even if you're a relatively high volume pediatric center, doing critical procedures at the bedside in an emergency department is still relatively rare. And physicians in general and freestanding EDs often perform no to zero or very, very few critical pediatric procedures per year. You want to do basic things like maintenance, having the time and space to have basic, the pediatric life support and pediatric simulation courses. Next slide. And same thing, Michelle, you can click through. Important facts to remember, children make up about a quarter of the US population. There's about 5,000 EDs in the US, but 80% of the pediatric ED visits are actually done to general emergency departments, right? It's not to pediatric specific emergency departments. EMS transport, it can be of critically ill children is relatively rare, relatively infrequent. 80% of EMS agencies see less than 8 children a month. We've talked a little bit about pediatric readiness and this concept, and we'll cover some more in a minute, but pediatric readiness means it's a type of weighted scoring system that you can do, that all emergency rooms do, as a way to figure out, are you ready with some basic equipment and techniques and supplies to care for a critical pediatric patient? Can you go next slide, Michelle? Part of that pediatric readiness is just making sure that you know what your resources are. Things like, who is the trauma center you partner with? For Southeast Ohio, a lot of that partnership is going to be with Nationwide in Columbus, right? They're going to provide a lot of your hands-on training and support. How would you be prepared with no forewarning? Thinking about, if most of these trauma patients, right, they come in without warning. How would you care for them? How are you going to triage if you have multiple patients? How are you going to stabilize? How do you make sure your staff is competent? Is a resuscitation bay set up for pediatric patients, right? Do you know where the equipment is? Does your staff know where the equipment is? Next slide. So pediatric readiness, what is this? Well, this is the ability of a healthcare group to care for critically injured children. It doesn't apply just to trauma. This is for all emergencies. And the National Pediatric Readiness Project, it's a multi-phase quality improvement initiative to ensure that all U.S. emergency departments have essential guidelines and resources in place to provide emergency care to children. It's making sure that you have a plan and the supplies. Hospitals with a high ED readiness score, that means you've taken this assessment for pediatric readiness and you've done really well, 4-fold lower rate of mortality in children with critical illness. Next slide. So why is this important? Why are we talking about pediatric readiness? Because this data is real. The data from 15, 20 years ago showing that there's very few children being taken care of. Most emergency departments didn't have basic pediatric supplies. Excuse me. That data was taken seriously. The Pediatric Readiness Project was taken seriously. And now other groups like the American College of Surgeons are recognizing the importance of projects like pediatric readiness and baking it into the standards for trauma centers. So not even just for emergency rooms, but for trauma centers, making sure that all trauma centers have a plan to take care of injured children. Next slide. So what are those pediatric differences? Like I said, I want part of this talk to be practical, right? We want to just not talk about theory, but I want you to be able to be prepared. Well, there's some true anatomic and physiological things, especially those things that apply in those first critical minutes of assessing and caring for an injured patient. Airway and breathing, right? You're talking about a small oral cavity, large tongues and tonsils. There's a large occiput. You need to know how to position the head appropriately, how to have the appropriate laryngoscope to get that floppy epiglottis out of the way. The head, TBI is a big problem, especially in small kids, right? It's the leading cause of mortality. They have a large head relative to the size of their body, so it tends to be the thing that takes that impact a lot. And the cranium's a little thinner, and it's less protective. There's significant force transmission. Circulation, this is a big one, right? Obviously in trauma, one of the things we're always concerned about is hemorrhagic shock. You have to be able to recognize shock in children. Remember, this is a young, healthy patient. They have a vascular system that's going to compensate the way you want to. Their blood vessels are clamping down. If you have hypotension, that's an end sign. That's one of the last things you're seeing right before them falling off that physiologic cliff. You need to be able to know what is kind of normal vital signs for kids and be able to recognize hemorrhagic shock. Next. And you can click through this, but again, for disaster medicine purposes, we talked about this on the list, but there really are some true physiologic differences, meaning higher respiratory rates, you have greater exposure, GI, that you have a higher risk of dehydration, again, from that exposure, higher body surface areas, so more skin exposure, increase for thyroid cancer due to that radiation exposure. Your thermoregulation is not the same. Kids get cold quickly, right? Being hypothermic is a big problem for all trauma patients, even more so in kids. You have to keep them warm. They're gonna get cold very, very quickly. Developmental, you think about their ability to escape an environmental danger, anticipate hazards. They don't have that same cognitive development yet. And psychological, that prolonged stress from critical events. You can go to the next slide. What can you do to be prepared? We have a variety of things that we want to make sure that you all have the resources that you need. It's hard to sum up in 10 minutes what exactly you need to do to be prepared for caring for an injured patient or a surge of injured patients. But the most important thing is that you have the ability to care for a single injured patient. If you've thought about that, if you've gone through the process, then you'll be much better prepared when there's a surge of patients. You can go to the next slide. You can click through this also. You focus on the basics. It's the triage and the primary survey, making sure you know how to triage that patient, and you can do the basic things. It's the circulation, airway, and breathing. Circulation, it's the hemorrhage control. You're stopping the hemorrhage when you can. You're getting the vascular access, and you're replacing with volume. When I think for each of those steps, how would you do that in a child compared to an adult? You secure the airway. Again, we talked about airway, making sure you know how to control the airway in a child. And that breathing part, it's that stopping that right heart compression, those two big physiologic things that are happening, that tension pneumothorax or the pericardial tamponade. How do you recognize that in a kid? How do you treat it just like you would with an adult? And the next slide, Michelle. One of the best ways to be prepared for this is with a pediatric champion or a PAC. That means you have designated individuals and hopefully one physician and one staff member to help you be prepared. And next slide. There's a lot of resources out there to be able to help you. One, reaching out to us personally, we are always happy to talk, but also all the things that we reiterated already from Deanna and Paula's talks, that there's lots of resources out on the web. We're happy to help out anytime. Thank you for your time today.
Great. Thank you. And hi, everyone. I'm Ann Runkle. I'm an EM attending at OSU and Nationwide Children's Hospital, and I'm the Associate Program Director for Ohio EMS for Children. I've also worked in 2 rural 10-bed EDs over the past 4 years, so I have some experience with the challenges as well as the benefits of treating children in community EDs. Michelle, do you want to introduce yourself?
Hi, I'm Michelle Moegling. I'm out of UH Rainbow Babies and Children's Hospital in Cleveland, Ohio. I'm a nurse by background with many years of PEDS ER experience. But for the last about 10 years, I've worked with our community EDs, 10 to 12 of them, on becoming pediatric readies, including 2 critical access hospitals.
All right, next slide.
Or anything different, just don't give the Vyvanse, okay? Okay.
Oh, Loretta, would you, oh, thank you. Thank you. All right, we're gonna get started. So for this talk, Michelle and I are gonna go through 3 cases with time for questions at the end. So what we want you to do is imagine that you're at your ED so you can think about how you would handle these. So it's a very snowy Monday next February. It's 7 a.m. and you get a call on the radio that EMS is bringing you an unstable 4-year-old that was hit by a bus just down the street. So as you're prepping for EMS, think about what resources you want to mobilize and where your pediatric trauma equipment is in your ED. So when EMS arrives 5 minutes later, you have a very concerning primary survey that you need to intervene on. So your heart rate's 169, can't obtain a blood pressure, your SAT 68% and a non-rebreather, and your GCS is 6. So start thinking about your ABCs. So airway, you're going to need to intubate. What size tube? Where do you get it? What meds are you going to use? Breathing, do you have a ventilator? Where's your RT? What are your settings going to be? And circulation, how are you going to give this kid blood and where are you going to get it from? Next slide. So for ET tube size, you can use the formula 3.5 plus age over 4. So in a 4-year-old, that's going to be a 4.5 cuff tube. If you go by age, if you go for weight, this kid is like a 12-kilo kid based on his weight and the Broslow tape. So he would actually be a 4.0 cuffed. You could use either one and it would be fine. If you can, I'd advocate for stocking cuffed ET tubes at your hospital for all sizes 3.0 and greater. They're going to prevent air leak. They're going to lower your chances of pressure injuries, and they're going to let you ventilate with higher pressures if necessary. For your laryngoscope, my blade of choice would be a Mac 2 for any kid between 2 and 8 years. If you go off a Broslow tape, it would tell you to use a Miller 2, but for a 12-kilo 4-year-old, that's going to be huge and a struggle to use, and a Miller 1 might be too small. So if you can, I'd advocate for a Mac 2. I would also advocate for stocking at least size 1 blades for your video laryngoscope to increase your chance of first pass success. So at the rural ED I work at, they're not able to afford to stock both size 1 and 2 GlideScope blades, but they have started working on stocking size 1 GlideScope blades to be prepared for difficult infant intubations. Your backup, if you can't get this airway, is going to be an LMA. So I'd advocate for stocking for at least size 1 LMAs in your ED and size 2 if you can. Next slide, please. So for vent settings, kids aren't that different from adults, so you're going to have volumes of 5 to 10 mils per kilo ideal body weight on the lower end for lung injury and the higher end for healthy lungs. And if this kid had a pneumothorax, one difference from adults is that your usual 14 gauge is going to be too big for needle decompression, so reach for a 16 or 20 gauge angiocath. And if you don't have pediatric sized pigtails, that's okay. You can always attach a stopcock and a syringe for transport. So your transport team is going to be able to keep taking air off of that pneumothorax in transport. Next slide, please. And then the next thing is this kid came in with significant tachycardia, which is hemorrhagic shock until proven otherwise. So the one number you have to remember for transfusion for kids is 10. For PRBCs, FFP, and platelets, a pediatric unit is right about around 10 mils per kilo. So the thing to keep in mind is if this 12-kilo kid gets 1 unit of adult PRBCs, that's a third of his blood volume. Next slide. So what's next? How do you get this kid out of your ED? So it's snowing, so no air transfer, and you're 2 hours by ground to the local children's hospital. When you go back to reassess your kid, he's tachycardic, borderline hypotensive, extremities are cool with modeling, and his abdomen's getting more and more distended. As Dr. Dingeldein was talking about, this is a kid on the edge. The next thing that's going to happen is he's going to code. What are you going to do now? This kid has a presumed intra-abdominal injury. Would your trauma surgeon take this patient to the OR? Have you talked about that at your hospital? If it's something you haven't talked about yet, something to talk about with your general surgeons. So say your general surgeon is there. She says, yes, I'll take this kid to the OR if they need to, but let's go to CT first so I can see what's going on. So you start transfusing more blood, go to the scanner. This kid's got extensive fractures, a grade 5 splenic lac with large extravasation, with active extravasation, and a grade 3 liver lac. Next slide, please. So in real life, this kid went to the OR with the local general surgeon who performed a splenectomy and packed the abdomen. The patient received twice his total blood volume and blood products, and despite the splenectomy and packing, had persistent tachycardia, hypotension, hypothermia, and needed an epidrip and high vent settings for transport to the children's hospital. Next slide. He had an incredible outcome. So he was extubated, he lived, and he was neurologically intact. The ED and surgery team saved this kid's life. The main preventable complications he had were difficult ventilation with a prolonged ICU course for weaning the vent. As you can see on that x-ray there was really significant fluid overload and pulmonary edema. And he also had significant subglottic stenosis. 2 things you could consider in the future if this kid shows up in your ED is be careful with your pediatric transfusions because fluid overload can cause pulmonary edema, prolonged intubation, and can cause refractory hypoxia that can lead to brain damage. Also, strongly consider using a cuffed ET tube if you can, because using large uncuffed tubes can cause pressure necrosis in as little as 15 minutes and can cause subglottic stenosis for your patients. All right, so you've got this kid going off to the children's hospital. You're about to sit down and drink your coffee on this snowy day, and a mom comes running in with a 6-week-old baby that looks like this. So you do your primary assessment, airways patent, no stridor, breathing, as you see in the video, so significant tachypnea, retracting with subcostal, intercostal, supraclavicular, nasal flaring. This kid is sick. When you listen to this kid's lungs, she has coarse breath sounds throughout with end expiratory wheezing, and her extremities are warm and well perfused. So in short, this kid has bronchiolitis. Next slide. So what do you do next in your ED? How do you suction this patient? How do you get vitals on a 6-week-old? And how do you give this kid oxygen?
So with suctioning, there's multiple different ways you can suction. You can suction with a bulb syringe, or if you're lucky enough to have a neosucker, those work very well. Neosuckers, as seen in the picture, are a little bit longer. They can actually connect to suction, and it's designed to minimize potential tissue trauma. You want to try and keep infants and children in the caregiver's arms as much as possible, even when suctioning them. If you need to help wrap them up in their blanket to help mom hold them while you're doing that, that works really well. You can also use the bulb syringe. If it's really thick snot like bronchiolitis, you can put some saline drops, but you really want to avoid deep suctioning, as it can just create more swelling of the nares and just cause more issues with breathing, because remember, they're predominant nasal breathers. When you're obtaining infant and toddler vital signs, you again want to keep that infant or toddler on the caregiver's lap whenever possible. Using distraction rewards such as stickers. Start with the least invasive before you try and triage this kid. Start with the respiratory rate. Ask the parent to lift up the shirt or undo their onesie, so you can just sit and count the respiratory rate without disturbing them. They want to look for retractions, head bobbing, nasal flaring. Look at their skin color. Listen for absent breath sounds, wheezing, or stridor. Then you want to do a heart rate. Listen with a stethoscope for 1 minute for infants. For toddlers and older kids, you can do 15 seconds, but it should always be done with a stethoscope. You shouldn't be using your pulse ox or your any other machine to get that heart rate. You really want to auscultate that for at least 15 seconds. You can use for the pulse ox, make sure that you have infant or the ones that have the tape on them. You can put it on a toe, on a finger. You can wrap it around a hand of a tiny infant. But be cognizant that that red light can be scary to kids. So let them touch it and feel it. And I a lot of times referred to as the red Band-Aid that's just going to give us a number. When you're trying to do a blood pressure on a kid, you're going to tell them that you want to give their arm or leg a big hug, and they can watch the numbers, but let them know ahead of time that it's going to get tight. In getting pediatric blood pressures, based on Lippincot's pediatric nursing procedures, the cuff should be about 40% of the arm circumference. And that should be midway between the arm and the shoulder, the antecubital part of the arm and the shoulder. Too small, you're going to get an elevated blood pressure. Too large of a cuff, you're going to get a low blood pressure. If you need to on an infant, if you don't have a small enough cuff to get it on an arm, you can put a small pediatric cuff on, usually on the leg, but really trying that. When you're getting temperatures, you really want to get rectal temperatures on infants less than 60 days that are presenting with any medical complaints. You want to avoid temporal thermometers on children under 3 months of age. They're actually not approved for that. You do not want to make sure you're not doing rectal temps on patients that are oncology patients or those that could have or do have or could have bleeding disorders. Vital signs can be based on your ESI of how often you're going to do them. Your ESA 1 or your ICU type patients, you should be doing the vital signs on them probably a minimum of every 1 hour. Kids that are on high flow nasal cannula or getting lots of treatments, you want to make sure you do them at least Q30 minutes for an hour, and then you can transition them once they stabilize to hourly. But for any patient in the ED, you want to make sure you get a minimal every 4-hour vital signs or based on your policy, but always trying to, if you're discharging somebody, making sure you get vital signs within that half hour before discharging them. So if they come back or they unfortunately have a bad outcome, that you've assessed them prior to them going home is really important. When you're trying to place oxygen on a child, this can be challenging because they don't want to have anything up their nose or on them because they're scared just being in the ER, let alone what we're trying to do to them. For nasal cannulas, again, caregiver involvement is key, having them hold the child in a way that they can't pull off the cannula. Having the guardian put one arm behind their back and then they can hold the other arm. Then you can put the nasal cannula on the child and hook it from the back rather than putting it under their chin and around their ears. And then turn on the cannula and the oxygen once you've had that cannula on there. You can also use some opsites like for your IVs and cut little pieces and put on their cheeks to help keep that. And then find something that can distract that child, whether it's mom playing a video on their phone or if you have an iPad or other distraction things. Those can be very helpful at distracting them from that nasal cannula. With high flow nasal cannula, like we saw used a lot with the RSV pandemic, you want to make sure you have the right sizes for kids. Make sure that you have infant and pediatric cannulas that fit your high flow nasal cannula adult devices. You want to make sure that the nares isn't completely occluded when you put that in. So make sure you have the smallest ones as well as the pediatric. And then follow your protocol for infants on high flow. Most of those kids will be NPO most likely because they're breathing hard enough that they're trying to just keep their oxygen sats up and compensate, that they're not going to be able to take anything by mouth without causing vomiting.
So the big things for bronchiolitis are suction, oxygen, so low flow or high flow nasal cannula, hydration, so either PO or IV, and antipyretics. As tempting as it is, steroids, racemic epi, hypertonic saline, and bronchodilators don't help. If the kid is over 12 months with significant wheezing and a strong family history of asthma or atopy, a trial of albuterol might be helpful, but I would focus on the basics first. So next slide. So on reassessment, your patient's still working really hard to breathe in high flow nasal cannula and her cap refill is 3 to 4 seconds. So you start calling for transfer, which is of course delayed due to the weather. And you realize this kid is going to need fluids because she's dehydrated. So how do you do it?
So placing an IV in an infant or child can be challenging, even for pediatric nurses. Especially with babies, you really want to start in their hand. Well-fed infants, you'll have a really hard time finding a vein in their AC. So always start with their hands. If they're coming in dehydrated or they're clamped down like this kid is, you're going to want to put some warm packs on for at least probably 5 to 10 minutes to see if you can get a vein to pop up. Usually you'll find something if you've put the warm packs on both hands. You also want to prep the child, depending on their age, for what to expect with that IV placement. Sweeties can be used for infants. It's just a sugar water that really helps them tolerate pain. Topical LMX cream, if you have that, to putting that on, and then putting the warm packs over it even, and that'll just help speed up the time of LMX. LMX usually needs to be on about 30 minutes, but by the time you get all your orders, get your IV stuff all set up, get the mom prepped for what's going to happen, it's about 30 minutes by the time you get to that, but really making sure you give that time to work. There are things like a wee sight that may be helpful for little infants. You can see it illuminates, you put it underneath the hand and then illuminates the veins, or you can use ultrasound guided IVs. The one thing I want to caution is don't ever use a light that is not approved for illumination for IVs, because some lights can actually cause 1st and 2nd degree burns on infants if you're using like a different type of procedure light. Distraction and holding kids down really doesn't work well. Distraction works well, but holding kids down with 4 people doesn't work as well as having that kid sitting in their mom's lap. And you can see here, distracting sometimes helps as well. You always want to make sure that you're going to let the kids know when you're going to stick. So if you have a toddler or somebody that understands what's going on, you want to tell them you're going to count to 3. But counting to 3 even can help the mom to make a tighter grasp on that child. So you can get that on the first stick. So push-pull IV fluids. What is the best way to give IV fluids rapidly if you have a kid that's dehydrated? For older children and teens, you can usually use a pressure bag and just crank that up and get that running in there pretty quickly. For infants and children, you can do what's called push-pull, where you can see here you have your T connector, and then you're going to add a stopcock, and then a 60 ml syringe for a toddler. For infants, you can just use 10 ml syringes. You can even use your flushes, your 10 ml flushes if you guys have those. So a 4-kilo kid would get like 8 flushes to give them a 20 ml per kilo bolus. So you're going to draw the IV, you're going to turn the stopcock off to the patient, draw it out of the bag, and then flip it off to the IV tubing on this far side and open to the patient, and then infuse it in. And you can continue doing that, and it can be done pretty rapidly. This would be something you'd want to set up and practice on before you have to do it on a patient if you can. One of the big things with this is make sure you're tracking how much fluid you're given. I've seen a lot of kids where they aren't tracking total volume, and these kids get fluid overloaded when they're trying to resuscitate, which just causes other issues on top of it. So either marking check marks or having somebody record and keeping track of not only how much you gave, but what's the total that's been given to the child.
All right, so the transfer center calls you back and they're on divert because it's another triple-demic, so you're stuck with this kid for 12 hours. Some maintenance things to do while the kid is in your ED or boarding upstairs is feeding. So it's generally a no-go on high flow nasal cannula, but you can consider on low flow if their work of breathing is okay. And if you have questions about this, you can always ask your referral hospital. Next slide. And monitoring, as Michelle already mentioned, they should all be on continuous pulse ox if they're on oxygen. And if they're on high flow nasal cannula, start out monitoring a full set of vitals every 30 minutes. Your default vital sign parameters on your monitor should be good for infants and children, but you can always check with PALS to confirm that they're appropriate. Next slide. And I'm actually going to skip this in the interest of time, but if you have to intubate the kid, position them well so you have a direct view, or you'll end up with a great view in your video scope, but be unable to intubate. Next slide. So you transfer that kid out finally, your referral center got off divert, and just as you sit down for your coffee again, you hear some noise up in triage. So you have a mom walking into triage with her 6-year-old son, who looks as you see on the right. So his airway is patent, breathing as you see on the video, his respiratory rate's 44, his SAT is 92%, his breath sounds are tight, he's not moving a ton of air, and he has expiratory wheezing throughout, but his extremities are warm and well perfused. So what do you do next? Next slide. So asthma scoring is fantastic and will really help your ED standardize your care for your patients with asthma. So if your ED doesn't have a standard asthma score, I'd recommend getting one in order to standardize your treatment of these patients. So Nationwide uses the asthma clinical score, but other scores you'll see are the PRAM and the PAS, and they all basically measure the same thing. So work of breathing, lung exam, and oxygen saturation. So for the ACS, you can score between 0 and 13 from mild to severe. So think to yourself what you would score this kid for a second. And you can also kind of put them in a bucket, so mild, moderate, or severe. When I go through this score, I would give him a 7. So he's tachypnic for age, but he's on room air, so he only gets a 0. Wheezing, he's got expiratory wheeze throughout. His air movement's tight, and he does have retractions. So if you go back to that GIF, you'll see that he has up to supraclavicular retractions. So this is this kid is moderate asthma exacerbation. Next slide. The benefit of an asthma score is that you can follow your children's hospital's asthma protocol. So for a kid with moderate respiratory distress, you could give 8 puffs of an inhaler. So go ahead and do every 20 minutes. You would do that times 3, or you could do back-to-back duo naps and then reassess this kid. The other key thing that you'll notice here for the initial treatment of asthma at your hospital is getting a steroid as soon as possible. So this is crucial and what could prevent an unnecessary transfer for this kid. So how do you actually do this? So how do you keep this patient calm and give him the medication he needs to get better?
So you could utilize comfort holds and distraction. Some helpful tips for procedures, or even give an aerosol. Plan for effective pain management, like if you're doing an IV or an injection. Distraction works well. If you have some bubbles, some pinwheels, light spinners, bubbles are each like individual patient, same with pinwheels. These are fairly cheap on like Oriental Trading Company. You want to make sure there's no choking pieces on some of the bubbles. So you have to be really careful that they have an attached wand to the top. Explain to kids what the procedure is at their age level. Using hugging, holding positions, giving aerosols. This kid's 6, so he's going to understand you a little bit more than most toddlers. So he can probably sit on his own and either do a face mask or a mouthpiece to get his aerosol. You really want to make sure to position for maximized security when you're doing things and maintain ease of access. Support a child's impaired involvement in roles with realistic choices, and always praise a child and parent when they're trying to hold still, listening. Keep them sitting up as much as you can, including letting them know when you're putting a tourniquet on that it's going to feel tight like a rubber band. I know sometimes you don't think of that stuff when you're in a hurry to get that IV on, but that can be the first thing to put that child over the edge if you don't let them know that. Let them know the alcohol will be cold, and always let them know that you're going to count and not just poke them by surprise, and always praise them afterwards, no matter whether they did good or bad. For meds, how are you going to give these? Bronchodilators, the HFA, using a mask versus a neb. If you're using HFA, you always want to have a child use a spacer. They should have a mask for young kids, and usually around 6 to 8, they can use a mouthpiece as well, but they should always be using a spacer with their puffer. And then which way is better to give a young child an aerosol? I'm going to tell you it's always A, with the mask against the face. Blow by, the further away you get, the least amount of medicine you're going to give them. You can see by this little graph over here, 6 inches away is like 30%. They're only getting 30%. When you have to give steroids, if you have Decadron, that's always the best choice rather than prednisone. But if you do have to crush or mix and give prednisone or anything like that, mix it with a small amount of flavor, whether you have a bottle of cherry syrup, you can use just a little piece of popsicle, Gatorade, or juice. The goal is always small volumes, though, if you're trying to get medication in kids, 3 mLs or less, and then offer rewards, stickers, popsicles, things like that.
So what do you do next with this kid? So if you follow your children's hospital pathway, you reassess 1 hour after starting treatments. So if you take a look on the left here, if their asthma clinical score is less than 2, you could discharge this kid home with steroids with no need to transfer. If they had an incomplete response, you can do another hour of bronchodilators and reassess. And this will vary slightly depending on your hospital's protocol. The main point here is that if you follow an algorithm like this from your children's hospital, many of your children with a moderate asthma exacerbation can be discharged home from your community ED. So with this kid, when you initially reassessed him, his ACS was 4. So you repeated an hour of bronchodilators, the steroids kicked in, and his ACS improved to a 1. So he was discharged home with steroids without having to drive 2 hours in the snow. So a final clinical win for your terrible snow day shift. Next slide. So just wrapping up this talk, I wanted to mention a few quick things. So first, children and youth with special healthcare needs make up a large portion of the pediatric population, and they can be challenging to manage in a community ED. So we've linked some resources to help you improve your ED's ability to care for these children and to partner with their families to provide the best possible care. Next slide. Second, we've mentioned in this talk a lot of pediatric specific equipment that might not make sense for you to financially buy a whole box of if you're not going to use it. So Michelle is a fantastic resource for cost sharing since she's done a lot of work on that in the Cleveland area. But we'd encourage you to team up with other EDs in your region or EMS agencies in your region to discuss sharing pediatric equipment. If one ED buys the size 1 LMAs and another buys the high flow nasal cannulas, you can share the equipment and decrease your costs. Next slide. And finally, if you want more cases like we've done today, I would plug the following resources. So on the right, there's the ASAP Sim Box, which has video-based sims for common pediatric scenarios, both hospital-based and pre-hospital. So you don't need your own mannequin. You just go through the facilitator guide and the video with vital signs. The ASAP EM resident sim curriculum for peds is also great. It's a book of 16 common peds scenarios that are already written out, and you can do it with a low fidelity mannequin. So some of my friends from residency do that for pediatric sim in their community ED, and they really like it as a resource. And then finally, if you have any questions related to pediatric procedures in the ED, the EMS for Children Colorado website has like 10 how-to videos on common peds procedures. So push-pull fluids, IO insertion, kind of doing bag mask ventilation for pediatric patients. It's a really great resource for training in your ED. And finally, if you have any questions related to peds preparedness in your ED, Michelle and I will both put our emails in the chat. And for Ohio EMSC, there's also, I'll put our program manager, Jessica Davis's contact info as well. Thank you so much.
Thank you, everybody.
All right, we are going to, oh, sorry, she's good. We are going to take a 5-minute break. So if you can come back at 3:13, oh my, 2:13, we will reconvene with our next speaker. And if you have any questions, feel free to put it in the chat. We are all watching it and can help with anything you need. All right, welcome back. We are going to get started again. I hope you guys got your cup of coffee and you're ready for an exciting presentation from Sara. So I will hand off to her.
Sara, you're muted.
Thank you very much, Michelle. My name is Sara Scheiwiller. I'm the BH Crisis Education Supervisor here in the BHP. And so in the BHP, we use a model called the stress model of crisis, or the therapeutic crisis intervention. And we refer to a stress model of crisis a lot when working with our kids with behavioral health concerns. So today for the next 40 minutes, we're just going to talk about what trauma is, how we can recognize it, and help prevent those pediatric crises for our kiddos. In talking, if you guys want to throw things in the chat, we will have a QR code for a couple questions we have in here. If the QR code's not working for you, you can put things in the chat, and I've got the poll everywhere here when we get to that. And if you guys do have any questions while we're going through it, it is a lot of information at once. Feel free to ask anything, and we'll knock through these next 40 minutes. Probably it's going to go really fast. So our first question, how comfortable do you feel working with pediatric patients who have experienced emotional trauma? So if you hit next slide, it'll pop up with a QR code and you guys can all answer this. Red being pretty uncomfortable, green being I feel pretty good, I'm good to go. And knowing that these answers are confidential unless you put it in the chat. But we want to acknowledge that it is tough to work with this population at times. So we're getting a pretty wide gamut. So in seeing these responses come in, it's pretty across the board. It's an uncomfortable feeling. It can be. We focus in healthcare a lot on what we can see and not always what we can't see. And I think with mental and behavioral health, there's a lot unseen and a lot that we're just not sure of, especially with our kids who can't always communicate what hurts or how they're struggling or what's making them uncomfortable or what they're afraid of. Recently, and as in recently, probably within the last 50 years or so, we've seen this trauma-informed care aspect start to sprout and grow. And that's kind of what today is about, is how we treat these kids in a trauma-informed way when they're suffering from things that we can't see. So if you want to head to the next slide. So trauma-informed organization supports and facilitates trauma-informed care through a couple different things. And the things that we pull out, we call it the 3 Ps. So we've got policies, procedures, and practices. So within your own organization's 3 Ps, there's things in there that feel trauma-informed and some things that may not feel so sure of. Different policies that we have here is we have, the constant attendant policy. So kids who are experiencing a mental health crisis will always have somebody within an arm's length of them to provide that support if they might be hurting themselves or others. Different procedures we have skin assessments to assure that our patients come in and if they have any skin breakdown, previous abuse allegations, that we're able to monitor that, and the practices that we have here in the building to support our kids that are going through a mental health crisis. So our intervention modalities, our de-escalation techniques. So every trauma-informed organization relies on those 3 Ps of policies, procedures, and practices. Go ahead. So a trauma-informed organization, we want to ensure that staff can do 3 things. So we want to understand what trauma is and how it impacts everybody within the system and what that looks like. Recognize behaviors and patterns that reflect past or present trauma, and respond in ways that avoid re-traumatization. So if you go ahead and hit next, there'll be another QR code and you guys can go ahead. And the first question will ask you, what is trauma and how does it affect everybody in the system and who does that affect? And you guys can go ahead and put your responses in. And again, if the QR code doesn't work, go ahead and put it in the chat. And while you guys work on that, to talk about what trauma is and how it impacts everybody in the system, I, in my naivety, thought that, oh, somebody have a question? No. I thought that trauma was reserved for people who had experienced war. And when I was in school, that's what I thought. And I got into healthcare and I started understanding what trauma was and how it does affect everybody, including our patients and our staff, who it affects, how it affects them differently. There's vicarious trauma, generational trauma, secondhand trauma. And it's just not things that are always at the forefront of your mind when you're trying to keep somebody safe and healthy and taken care of. And here we're getting a lot of, it affects everybody. How do we understand? We can listen, be open-minded, and understand how diverse it can be. Mock situations to help prepare for trauma. It's a lot. Any distress a patient experiences, and anybody can go through it. So the fact that trauma affects everybody differently. I read somewhere that trauma is anything that your brain cannot handle in that given moment. So what might be traumatic for me in this moment might not be traumatic for me next week, but it is right now. And so trauma can look very differently, and it can manifest in different ways. The next question that's part of this will be that understanding what trauma is. So we'll talk about this a little bit later. We call those pain-based behaviors. So what behaviors do we see from our pediatric patients that may reflect trauma? We call this pain-based behavior because it's rooted in pain. And looking at this, there's pain-based, and a lot of staff and people in the community look at these as pain in the butt. And we want to make sure that we keep looking at these in ways that this is the language of trauma, and how can we not have compassion for that? So understanding what those behaviors are. If you want to go ahead and start putting behaviors that we see. Oh. If you want to go back a couple. Oh, we're not there quite yet. One more. There you go. All right, so we call these behaviors, those pain-based behaviors again. That might look like defiance, trauma reenactment, inflexibility, overreaction. We have a lot of kids here that escalate over mealtime. Yep, anger, crying, not wanting to be touched. When we talk about trauma reenactment, a lot of people think that that stems from a lot of sexual trauma, and knowing that that could be anything. I worked a lot with our children with autism, and we had a patient come in, and it was when we were wearing masks, and he would slap me, and then he'd pull my mask off and he'd be like, "Is that okay? Is that okay?" And he was recreating that trauma that he had seen in his home of domestic violence. And so knowing that that can look differently for every kid and what that means for them, and then responding in ways that avoid re-traumatization. So some ways that we can respond differently to our kids with traumas, doing things like getting down on their level, using age-appropriate communication, making sure we're talking to them like a kid still, using that active listening piece, and validating those feelings and experiences. A lot of kids that come in with emotional and physical trauma have learned through violence to get their needs met. And so showing that kid, hey, let's talk this out versus act this out. All right, I'm ready for the next one. So this is Zoe. We're going to watch a quick 2-minute video on what Zoe's experienced in her childhood, and then we're going to do kind of a self-awareness practice with that piece.
Sometimes someone hurts you so bad, it stops hurting at all. Until something makes you feel again.
I don't think you understand.
And then it all comes back. Every word, every hurt, every moment. How could you ever understand where I come from? Even if you ask, even if you listen, you do not really hear or see or feel. You don't remember my story. You haven't walked my path. You haven't seen what I've seen.
All right, next slide. So a couple discussion questions to look at this trauma that these kids might experience before coming into our care. And you can put your answers in the chat or come on off of mute. What do you think Zoe is experiencing? So what kind of trauma do you think Zoe is experiencing? I think there can be a lot that's going on in that house that we might not see, but there's domestic violence, there can be abuse. She is the caretaker to her younger brother. She might not be getting her needs met, fear and being trapped, mental abuse. There can be a lot that's going on with our kids that we're not even aware of. And so keeping that in mind when we have kids that come into our care that have experienced trauma, Zoe's perception about adults is probably not very good. It's hard to get a kid in our care and feel like we're doing what's best for them and not feeling trusted by our kids. But the perception that these kids have about adults is not always a good one. And so that's something that we want to remember to have compassion towards. Behaviors we might expect to see from Zoe and what might trigger those behaviors. You guys probably see this in your ED when kids come in. They might have a fear of a certain gender of staff. They may loud noises. They might try to run away. They might be defiant, fearful, act older than their age. We've got some kids in here that come in and emotional, mental, verbal abuse, and physical. Tiffany, you're right. We're just not always sure. What will she need to feel safe? So this is one that I'll leave up to the chat. We talk about safety in a couple different ways. So a lot of times we capitalize on physical safety, but also acknowledging that kids don't only need to feel physical safe, they need to feel mentally safe as well and emotionally safe, and that there's a difference in that. Objectively, our kids are very safe in our care. They have a roof and their needs met, but if they don't feel physically safe or emotionally safe, then the work that we're doing might not be as beneficial as if they do. They might get shy from smells and sounds, absolutely, especially with perfumes. We've got a lot of kids that respond differently to different staff based on the perfumes that they wear. So it's just kind of that self-awareness practice. Next slide, please. So those effects of trauma, if we look at this from a neurological perspective, we've got the survival brain, the emotional brain, and then that thinking brain for our kids. And the brain kind of develops from that base upward. And so the brain stem, that's where those kids' fight, flight, and freeze response lives, and also where staff's fight, flight, or freeze response lives. A lot of times when kids come into crisis, they're in a natural fight state. And neurologically, when your neurons are firing back and forth from one another, if a kid comes in and fight, you fight as well. And so acknowledging, these kids are in emotional distress and that it takes a toll on staff too. We want to try to get those kids into that emotional part of their brain that hopefully can send those signals up to the thinking brain. So to get those kids in those emotional brain, we'll talk about that briefly today. When kids perceive danger or threat, it goes straight to that emotional brain. We call it the high road and the low road. The low road being it goes down to that survival brain and the child learns to fight to get those needs met. We're hoping to help develop that thinking brain for those kids to get that firing up to a more logical, reasoning, abstract thought part of that brain. So the survival brain, a lot of our kids live down there, and knowing that it's not always a choice. Sometimes these kids come in and they have really acute behaviors, but knowing that these are pain-based. And so a kid is showing us that they're experiencing trauma because they're not able to tell us. Next one, please. So the build of a crisis, we call this the stress model of crisis, knowing that the child starts at baseline. If a kid was at baseline, we likely wouldn't be seeing them. But that baseline, you can have good and bad days without going into that crisis. Next, we've got that triggering event. So there's something that happens that gets them starting to go up that stress model of crisis. You see these dotted lines, that's what we call off ramps, meaning that we want to take these off ramps to get back to that recovery phase before we continue up that stress model. Because next is escalation, which is met with aggression. So a lot of our kids in this phase are starting to clench their fists. Knowing when a kid ticks upward is really important when you're looking at the stress model of crisis. And then ultimately that outburst. So this is what we call that kid's lid, it pops. And a lot of times we see violence at this point, and then heading back down to that recovery phase. That recovery phase has 3 different outcomes. We've got higher, no change, and lower. So we hope that when we hit that recovery phase, we're able to take that higher outcome with our kids, and knowing that sometimes a restraint might be necessary, or knowing that medication might be necessary to get us down to that recovery phase. And in a little bit, we'll talk about how we can offer that. Next, please. So just to think, Zoe that we just watched comes into your emergency department and currently has no disposition plan. While in the emergency department, she has had 3 escalations regarding the male staff partaking in her care and is now labeled an elopement risk. She has been in the ED for 36 hours, and a code violet was just called on Zoe for hitting staff who came in to obtain vitals. So go ahead and go to the next slide, and then we'll put the answers to these in the chat. So when this happens, what are you feeling? What is that knee-jerk feeling that you get? I think it scares a lot of staff initially to see a child come in. She might be afraid of men. That feeling that you feel first is that first checkpoint. So this is a self-awareness assessment we do for ourselves. So knowing that these are in order, because if you're not answering good on the first question, stop there, right? So what am I feeling? Worried, nervous for the patient and staff, anxious, maybe you're fearful. How can I help her? So there's a lot of different feelings that go on to this when you see a child in emotional distress. What does that child feel, need, expect, or want? And so that kid has needs, right? And she's expecting things. You want to take that expectation and defy that. So she's expecting adults to be mean to her. She's expecting men to hurt her. She's expecting to have to take care of somebody. Protection. Christy, that's great. A lot of these kids, they just need help, and they view adults, even us, as people that might hurt her based off of her perception of us. And so if we're able to protect that kid and shield that kid and help that kid, we're able to turn this space from hurting into healing and create this a good space for her. How is the environment affecting the situation? Knock on wood, I haven't been to an emergency department in a while, but they are very overstimulating. The lighting, the amount of people, the noises, the environment itself is kind of closed off at some places. So knowing that that environment can affect it, especially with our kids with autism, the noises, the people, the crowds, the audience. If we can help a kid de-escalate just by altering that environment, that's a pretty good day. Lastly, how do I best respond? Given your tools and your resources, how do you best respond? So is it I intervene emotionally, I verbally de-escalate? This might result in a restraint. This might result in removing the kid or the audience or the other patients. So that self-awareness, we can remember that as what, how. So what am I feeling? What about the kid, that environment? And then how do I best respond? Michelle, go ahead. So this is an iceberg of behavior. We use this a lot. If you're looking at an iceberg up in that Arctic, what you can see at the top is all you can see. So when talking about our kids, all we can see are those behaviors. We can't see what's underneath that. So a lot of our kids are dysregulated when they come in. They have difficulty focusing. They're defiant. They're crying. They might be aggressive. But underneath that iceberg, which is the belly of it, are all of these feelings. So they've got low self-esteem. Their basic needs are not getting met. They need connection. They feel angry. They don't feel physically safe. And so what we can't always see is underneath that surface. So all behavior has meaning and drives how we ultimately respond to that. Next one, please. So we're going to talk about that triggering event and what agitation can look like with the kids that we work with. Michelle, go ahead. Thank you very much. So some potentials for our kids, and if there's something that you guys have experienced that's not on this list, feel free to put it in the chat. Feeling unheard, unmet needs, conflict with caregivers. A lot of our kids who come in crisis don't agree with their caregiver that they should have to be there. So the conflict with caregivers is a big piece, or they don't agree with how their parents are handling their situation. Receiving bad news. Some of our kids come in after just receiving or hearing that maybe their friend had passed, or parents are giving up custody, or they get dropped off and they're not coming back. Being bored. I think this is a big one. And so a lot of our kids come out and they start to escalate because they're bored and they're not sure what to do with their time. Kids with mental health really do crave structure and stability. Changes in routine. During COVID, we saw this a lot. A lot of our kids lost their resources based off of school being canceled, after school activities being canceled. So the changes in routine can be really big. Limit setting. So there's a difference between setting limits and maintaining safety. And can be difficult to remember at times. Medication changes or conditions. Kids come in, they get a medication change. The side effect can be behavioral, and keeping that in mind when we're treating our kids, or being provoked by patients and staff. Do you guys feel like I missed anything in that list? Not exhaustive, I'm sure I have. All right, Michelle, I don't think I did. Go ahead. Thank you. So again, all that behavior has meaning, and that behavior is reflective of their emotions that they're experiencing and the needs that are unmet for them. Trauma affects the ability to manage feelings and behavior. So if, again, kids knew how to say how they felt and advocate for their needs, we might not be seeing them in our hospitals. But behavior is the language of trauma. Children will show you before they tell you that they are in distress. So really finding that compassion piece in their behaviors and looking at those behaviors as the language of trauma. If you take anything away from today, behavior is the language of trauma. Go ahead, Michelle. So this part, how do I best respond? And this one is tricky. How do you best respond? So you want to stay in control using that positive self-talk. I don't think it's right to talk about the salt without the pepper. Everything is not always positive. Sometimes these kids come in and it's really hard and you're not sure how to keep yourself going. And there's some of that negative talk creeps in. But if we can't counteract that with that positive self-talk, I'm running to codes and I'm like, it's okay, Sarah, hurt people. So whatever you've got to say to kind of keep yourself going, keeping yourself engaged and here for the right reasons, which are our kids. Provide that environmental support, shutting doors, giving kids privacy. If I had everybody in an emergency department watching my worst moments, I'd be really embarrassed. And after a lot of our escalations with kids, they feel very embarrassed. They don't like how they've acted. Once they kind of come to it, providing that emotional support, being there for them, listening to them. A lot of them just need somebody to listen, somebody to validate their experience and decrease that level of stress if we're able. If it's they come in and they're hungry, we can give them food. If they come in and they don't feel safe, we can, show them that this is a safe place. Next, please. So emotional first aid, these are quick fixes. So when you think of first aid, you want to think of kind of like a Band-Aid. So how can we quickly and safely keep everyone safe? Strategies. So we'll talk about the strategies before we get to the goals. You want to co-regulate those emotions. So you want to make sure that you're calm. If that kid comes in at an 8 and we respond at an 8, the kid will naturally go to a 9, and we'll keep mirroring each other until the escalation evolves continuously. Maintain the relationship and lines of communication. I have been on the receiving end of some silent treatments, and it's not fun. And so our kids, again, we want to remember their expectations of adults and the perception of adults. So keeping that communication open. With this relationship piece, a lot of the work that we do is relational. And so if a kid can trust you, we're halfway there. And you want to be a coach. So plan and anticipate what's happening next. And if we can keep these strategies, we want to then do this with these goals in mind. So we want to reduce that emotional intensity. This kind of reminds me of the recycling, reduce, resolve. What is it? Reduce, reuse, recycle. We want to reduce emotional intensity, resolve the underlying concerns and distress if able, and then we want to keep that kid in the activity. So some of these things our kids aren't able to not participate in: assessments, family sessions, blood draws, imaging. Those are things that we have to do. So we want to keep them in there, return them to that as soon as we're able. Michelle, thank you. It's not what you say, it's how you say it. So our kids in crisis, they'll see you before they hear you. So again, the facial expressions and the tone of voice outweighs what you actually say. When I go home, I talk to my dog and I've got this great tone. I'm like, Boomer, you a good boy. He has no idea what I'm saying. I'm smiling, my facial expressions, my tone of voice is really happy, and it's great. But as soon as I come home and he struggled, he sometimes might eat a sock. And I pull the finger, I'm like, Boomer. And he has no idea what I'm saying, but he sees my facial expression and my tone. And so again, kids in crisis, it's like that mirror in your passenger. Objects may appear closer than they are. Kids see you before they hear you. So facial expressions, tone of voice. This is also important in how we offer medications to our kids. If we tell a kid, if you don't do XYZ, you're getting meds, that's fearful. And we don't want to use it as necessarily as a threat, but medication more as a tool to help bring our kids down to a level where we're able to continue working with them and de-escalate. Next, please. So that importance of body language. So up there in the top left corner, we've got our arms crossed. The one with the ponytail looks very engaged and nice, but it's kind of sending that message of, hey, I'm here. I'm not really listening. The parent finger is what I call that one. When you pull the finger out and you start pointing, it feels very authoritarian to our kids. This guy looks very frustrated in the top right corner. Our kids see that, they can sense that. The one in the bottom left, she does look very friendly. I will give her that, but her hands are in her pockets. What do kids might think are in our pockets if our hands are in them? Anything, right? Medication, shots. Our middle one, she rolls her eyes. And the other one is eye contact. So eye contact is important to remember because there's a cultural piece to it, a gender piece to it. Some of our kids find that very intimidating and threatening. Other kids see it as respectful. So keeping in mind the amount of eye contact that we use in these escalated situations. Next, please. So summarization, when talking with a kid, we want to make sure that we listen and validate. So summing up that feelings and content, and it allows the adult and child the opportunity to make sure that they're on the same page. So it sounds like you, or let me see if I got this right. Stop me if I miss anything. And they'll tell you if you miss something or if you're not getting it right. But it just shows that you're listening and that you're there to support them. And this is where we start to change that perception of adults. Next, please. So we're going to do one of these. We'll just do one so we can skip over the next two. But in the chat, you guys can answer 1, 2, or 3. You enter a patient's bedroom to remind them at dinner that dinner will be up in 5 minutes and ask them to begin cleaning up. The patient stands up and yells, "I'm so sick of you always telling me what to do and having to follow these stupid rules. I just want to leave." So in the chat, what is the best response to this situation? Well, I'm tired of telling you to clean up after yourself. 2, I hear that you're tired of being told what to do. What if we cleaned up your coloring sheets together? Or 3, what can I do to help you follow the rules better so that I don't have to tell you what to do again? Yep, it's 2. Absolutely, it's 2. We might feel like saying 1, well, I'm tired of telling you to clean up, but that's, again, when we're practicing that self-assessment, how do I best respond? That's not our best response. But number 2, it tells you, I hear that you're being tired of told what to do. We're not assuming anything. We're taking the words right out of the kid's mouth. You are tired of that. And you're offering that solution. So what if we cleaned up your coloring sheets together? That we piece is really important to our kids. A lot of times they don't have outside support or outside adult engagement. And so showing them like, hey, we're here to help you. What can we do? We'll help you clean up together. If you find yourself saying, I don't have to do that again, anytime again or at least is in one of those, we try to stay away from that. It can be invalidating to our kids. Michelle, you can skip over the next 2. All right, so now we're at outburst. So this is where we start to see violence from our kids, and how we're going to co-regulate with that will be in our next slide, how we help get that child back down to that recovery phase. Michelle, go ahead. Co-regulating with a child in crisis. So when intervening with a kid, quick responses and actions is required. So there's kind of 3 buckets we talk about in our head. So there's what to think, what to do, and what to say. So we always want to make sure that we're thinking before we do anything, and we're doing things before we say something to maintain that safety. And sometimes that space or that intervention that's required. Next, please. So that what to think, again, that what, how, using that positive self-talk and remembering that safety is always our top priority. So safety for the patient, safety for staff, and once everything's safe, we can continue to move onward, but safety is always number 1 important. Be proactive. Your relationship matters. I'm more likely to talk to somebody if I trust them and I know them versus if I don't. And it's really easy to make a relationship start with our kids. We have a staff member here who wears Naruto t-shirts and yellow sneakers just to try to connect with a kid. And so if it's their birthday, if it's their favorite food, those relationship pieces, relationships are built off of small things. And don't take it personal. The child's in crisis and you just happen to be in the way. And it's hard to not let it get to you and feel like it's your fault, but you're here for the right reason, and that's for the kids. Next slide. What to do. So some low-level interventions that we can do to help a child de-escalate. It's that active listening. We want to take a deep breath. So we want them to catch our calm. We've had a child in restraints who was breathing really heavy, and we had a staff member take that deep breath, and he couldn't see the staff member, but he heard it. And you see him start to take those deep breaths with the staff. It helps regulate you and the kid. So co-regulation, we want to do this together. Utilize silence. Silence can be very uncomfortable, but it allows the child space to fill it. If it's safe, step out. Again, if I was in a crisis, I wouldn't want everybody around me watching me. And if it's safe, you can go. And if you can't go, remember the importance of that body language, facial expressions, and then your tone of voice when we get there. We also want to avoid those power struggles with our kids. Power struggles is a part of development for children, and we can easily get in them with our kids who are in crisis. Next, please. And then remembering risk versus risk. So safety is always our number 1 priority, and there's some risk versus risk is kind of that trifold critical thinking, right? So it's not what if I do something, it's what are the pros and cons of if I do something, and what are the pros and cons of if I don't. So some considerations to make while assessing safety in these moments is your physical position in space. So knowing your exit points, knowing where other patients are, knowing where your support staff is, the clothing that you wear. Is your hair up? Are you wearing a scarf? Do you have shoes with backs? Remembering these things when working with these kids, your instincts, so trusting your gut, patient baseline. So if we can intervene quicker because we know the patient baseline, then we're able to help get that kid back down as soon as we can and as safe as we can. And the varying patient acuity, especially in an emergency department, when you've got your behavioral health kids right next to a medical patient, knowing how that can escalate one another. Our patients need our help, and we need to help them the best way that we safely can. And that safe piece is important. We talk a lot about patient safety, but staff safety is priority as well. Next, please. So we've got those elements of a potentially violent situation. We've got the spark, the target, the weapon, and then that level of stress or motivation. So these are kind of the mixing pot for a potentially violent situation, and knowing what resources you have available when there is a weapon involved, or you might be the target. So getting yourself out of those situations, and then what's really sparking that, what's really getting that kid to start to escalate. Next, please. So again, just to recap, you want to make sure that you keep yourself safe. So in these escalated situations, be alert, consider your nonverbals, your body language, so situational and self-awareness. Anger equals distance times 2. So keeping an appropriate distance away from the kid. If that kid is withdrawing and they're very upset, knowing that getting on their level is important, but that there's safety risk involved in that. Finding help, grab a wing person, use available resources if that's NCH resources, hospital-based resources, and empathizing with them. So remaining calm, validating, consider their experience or their perspective. The hospital can be a scary place. Next, please. Debriefing with the kids, so they might not want to talk to you right away. And we might not be ready to talk to them yet. It might be a delicate and volatile time for them. Both staff and child might not be ready to immediately go into it, and that's okay. But when these situations arise, how do we navigate these? So debriefing is important, not only for us, but for our kids. And we talked about trauma. I've taken things home that I've seen, and it's hard. I've had staff take home things that they've seen or been a part of. So making sure that debriefing is not only a priority for our kids, but for staff as well. After the crisis, we want to keep the kid engaged in preferred activities. So debriefing is learning. There's a huge learning element in that. So what do they like to do? How can we avoid this in the future? What went well? So keeping those kids in the preferred activities, keeping them as comfortable and feeling as safe as they can. Create a routine and or schedule. So kids with a trauma, again, they're not always sure what to expect. And so when you create those structures and put expectations in place, it does really well for them. Create expectations for them. So expectations differ from rules. Expectations are rooted in kind of those preferred outcomes. Rules are for safety. So when we talk about power struggles, expectations, they change per patient. Rules do not. So not allowing a patient to hit you, not allowing a patient to throw bodily fluids, right? Those are rules. Expectations might be, hey, we're going to engage in this activity for 10 minutes. So that expectations can change per patient. And making a referral. So next we'll get into our referral process here at Children's and the BHP. So this is the inpatient process. This is the official communication that's gone out to all the varying hospitals. So you can call 614-938-0013 and select option 3. We have a referral, 2 people who work on our referrals daily, and you can ask them if they're accepting referrals. They'll make sure that this is up to date by 9 a.m. and then they update it again around 4 p.m. if there was a change. If no beds are available, then you can call the next day. If beds are available, YCSU or inpatient, then they would need clinical information in the NCH referral form, fax to that number below. So that referral form is on our website as well. If an incomplete referral is received, they'll send it back to you, or a new one will need to be sent if you don't get that back within 24 hours. All complete referrals received by 12:30 will be reviewed by the covering psychiatrist in our psychiatric crisis department. A call will be made once disposition is determined by the psychiatrist, no matter what it is. So they'll always call back. If they're accepting on this call, the next steps will be discussed on that call. And if they're declined, they may try to help you send out different areas in Columbus. So we've got Sun Behavioral, but they can help find other places for that patient to go. And feel free to follow up daily regarding bed availability. There's also on the Ohio Bed Board, it shows if we're making accepting referrals. Next, a couple outreach numbers that I looked up based off of the people I knew were coming today. Partner and provider line. This is an NCH number for anybody who has any questions about linkage, resources. They're really helpful. 614-938-PLAN. Outpatient services. So if a patient in your emergency department needs linkage to a clinician, patient's getting discharged and they just need services, the statewide youth crisis MRSS line, as well as the Hopewell crisis line and the Washington County local crisis line. So if a patient is discharged and they're not sure what to do or who to call, these are resources and numbers that you can provide your patients. And lastly, I hope you guys have a great day. Do you guys have any questions for me? Well, I appreciate you guys and all of your time.
All right, Michelle, if you want to go to the next slide. Okay, so we are going to do, if we could just finish up, we have 3 short questions to finish up, just kind of evaluation to see your response to the activities we've done. So if you could scan the QR code.
And then we'll have information about the CME and CE.
Oh, and then after that, yes, we will review that after we do the poll.
Shelley, for those
Yes.
who log on to the poll via the website, it is POLLEV.com. There is an extra dot in your link. So I just want to make sure that folks know that it's POLLEV.com/Shelley Brackman 358.
And Michelle, you can go to the next slide. So we are very happy that you improved understanding on the pediatric disaster plan. Please feel free. The websites of at least all the contact information will go out on our website, and we really tailored that to you. So please use those for your emergency departments or your hospitals. And we're here for you. All right, we'll go to the next question. Alrighty, and then the last question is just an open-ended question. What elements, it's kind of free text portion where you can, it must have got uploaded, but feel free to answer any questions or put any feedback, or you can put feedback in the chat, whichever you prefer.
For those of you with nursing CE, you will receive a link to a REDCap survey that must be completed in order to receive your CE. You must complete this within 2 weeks or you will not receive credit. It does shut off exactly at 2 weeks from today. For CME, following completion, which is now, text code 59213 to this number for your CME. This will not be active until probably 3 o'clock because we were supposed to go till 3 o'clock. So after 3 o'clock, you can do that. So take a picture of this if you are looking for CME, so you have the code and the phone number. And I'll leave it up for a few too as well. I'll come back to it.
Does anybody have any questions or feedback that they would like to give? Look, yeah,
Shelley
give
and
you-
group, this is
Oh, go ahead.
Kelsey with COTS, and I just want to say thank you guys so much for providing this opportunity to the Southeast Central region, and thanks to all of our attendees today. Look forward to additional engagement in the future. So thank you guys so much for taking your time today.
And this is Deanna Dahl-Grove. I will echo Kelsey's ability to work with us and all of your partners in Southeast and anybody else that isn't from Southeast. That's so much from all of our colleagues at Region 5 for being on this webinar. I hope you found the information helpful, and please realize that you can reach out to us at Region 5 through the contact general information just to ask us any questions, other resources, tools and stuff. We're experts in taking care of kids, and we want to help you become more comfortable if that's a great option, and really encourage you to reach out to us. We love what we do, and we're very excited to be able to help you.
This concludes our webinar, and have a wonderful day. You get
Thank you,
6 minutes
everybody.
back.